Hello everyone and welcome to Blood and Hematology YouTube channel. This video is about patient case number 1 discussion. The patient was a 56-year-old woman with fatigue, fever, neck swelling, cervical lymphadenopathy, elevated CRP, liver enzymes, LDH and ferritin levels, leukocytosis and reactive lymphocytes. C-reactive protein, CRP, is a pentameric protein synthesized by the liver and has been recognized as the prototype acute phase reactant and as a marker of inflammation, infection, and tissue damage. Elevated liver enzymes often are a sign of inflamed or damaged liver cells. The most common elevated liver enzymes are alanine transaminase, aspartate transaminase, alkaline phosphatase, and gamma-glutamyl transpeptidase. Some causes of elevated liver enzymes include fatty liver disease, metabolic syndrome, hepatitis, and cirrhosis. Lactate dehydrogenase is a cytoplasmic enzyme that is present in almost all tissues but at high concentrations in muscle, liver, and kidney. Conditions that can cause increased LDH include liver disease, anemia, heart attack, bone fractures, muscle trauma, cancers, and infections. Ferritin is an acute phase reactant released by activated macrophages and damaged hepatocytes. High ferritin levels are most commonly caused by inflammation, infection, liver and renal diseases, alcohol excess, metabolic syndrome, and malignancy. Reactive lymphocytes are generally regarded as immune-stimulated T or B cells with upregulated synthesis of inflammatory mediators and antibodies. They are usually associated with viral illnesses, but they can also be present as a result of drug reactions, immunizations, radiation, hormonal causes, and as well as some autoimmune disorders. Some pathogen-related causes of increased reactive lymphocytes include Epstein-Barr virus, cytomegalovirus, Toxoplasma gondii, Treponema pallidum, hepatitis C, and hantavirus. Respiratory infections testing showed elevated anti-EBV antibodies, and the patient was diagnosed as EBV-induced infectious mononucleosis. Infectious mononucleosis, commonly referred to as mono, is one of the most prevalent diseases in childhood. Infectious mononucleosis most commonly affects adolescents and young adults with a peak at 15 to 24 years of age worldwide. IM is characterized as a proliferative disorder of the mononuclear macrophage system in the body. The primary clinical manifestations include the classic triad of fever, tonsillar pharyngitis, and lymphadenopathy. The majority of IM cases are caused by infection with the EBV. According to the CDC, examples of other causes of mono include CMV, hepatitis A, hepatitis B or hepatitis C, rubella, and toxoplasmosis. EBV is a highly prevalent human herpes virus worldwide, disseminated in 90 to 95% of the adult population. EBV was identified in 1964 by Anthony Epstein and Yvonne Barr, using electron microscopy in cultured lymphoma blast cells from tissue samples of patients with Burkitt lymphoma. The association between infectious mononucleosis and EBV was pointed out by Henley et al. In 1968. EBV infection is associated with a variety of diseases, including infectious mononucleosis, B-cell cancers, some types of epithelial cell cancers, and certain types of gastric cancer. Evidence also suggests a link between EBV infection and certain autoimmune diseases, such as Sjogren's syndrome and systemic lupus erythematosus, but the exact mechanisms of this relationship are still unknown. EBV infection was shown to significantly raise the risk of developing multiple sclerosis. Patients suspected to have infectious mononucleosis should have a complete blood cell count with differential count and a peripheral smear performed. Peripheral blood leukocytosis is observed in most patients with infectious mononucleosis. Lymphocytes make up at least 50% of the white blood cell differential count. The disease course is associated with atypical lymphocytes in peripheral blood and internal lymphoid organs. They constitute greater than 10% of the total lymphocytes, and an absolute increase in atypical lymphocytes during the second week of the illness is characteristic of infectious mononucleosis. Additionally, peripheral blood can be assessed for the inflammatory markers, neutrophil to lymphocyte ratio and monocyte to lymphocyte ratio. Studies have shown that in children with IM, NLR, and MLR are inversely correlated with liver damage, making them potential laboratory indicators for assessing the severity of the condition. Early detection of EBV infection is crucial in aiding the diagnosis of infectious mononucleosis. Laboratory methods for EBV detection include heterophilic agglutination tests, Epstein-Barr encoded small RNAs in situ hybridization assay, EBV-specific antibody assays, EBV DNA load measurement, and EBV virus culture. Heterophilic agglutination tests, considered the most commonly used serological assay, offer advantages such as distinguishing primary from recurrent infections, cost-effectiveness, and simplicity. However, due to lower sensitivity and specificity in children, its clinical use has diminished. EBA's in situ hybridization assays, regarded as the gold standard for clinical EBV diagnosis, are often performed on pathological tissues. While operationally complex, they are primarily employed in diagnosing EBV-related tumors. Different stages of infectious mononucleosis are associated with different EBV-specific antibodies. For immunocompetent children, testing for antibodies including antiviral capsid antigen IgM, anti-VCA IgG, and anti-Epstein-Barr nuclear antigen IgG can differentiate recent infection from past infection. Anti-VCA IgM appears first after exposure to the virus. In the early stage of the disease, a significant increase in VCA IgM is observed, serving as a hallmark of recent EBV infection, with specificity and high sensitivity, lasting for 4 to 8 weeks, and being a major basis for clinical diagnosis. It is important to note that although VCA IgM antibodies are specific to EBV, they can also be positive in CMV infection. VCA IgG antibodies are primarily low-affinity antibodies during the acute phase, transitioning to high-affinity antibodies during the recovery period. Anti-VCA IgG appears in the acute phase of EBV infection, peaks at 2 to 4 weeks after onset, then drops slightly, stabilizes, and is present for life. Antibody to eBNA, determined by the standard immunofluorescent test, is not seen in the acute phase of EBV infection. Instead, It slowly appears 2 to 4 months after onset of symptoms and persists for the rest of a person's life. Anti-early antigen IgG appears in the acute phase of illness and generally falls to undetectable levels after the 3rd of June months. In many people, detection of antibody to EA is a sign of active infection. However, 20% of healthy people may have antibodies against EA for years. EBV DNA load serves as a direct indicator of viral replication within the host. A research indicates that the combined assessment of EBV VCA-IgM and real-time polymerase chain reaction for EBV DNA load significantly improves sensitivity and accuracy in diagnosing infectious mononucleosis compared to individual tests. EBV virus culture is not commonly used in clinical diagnosis of IM due to its lengthy incubation period, 2 weeks to 2 months, time-consuming nature, high cost, and complex technical requirements. Certain cases of infectious mononucleosis may present with complications such as hepatic and cardiac involvement, as evidenced by elevated levels of transaminases, creatine kinase, and CKMB in laboratory examinations. It is suggested that adenosine deaminase exhibits high diagnostic accuracy in predicting infectious mononucleosis and anticipating elevated alanine transaminase. ADA not only aids clinicians in early infectious mononucleosis diagnosis, but also serves as an indirect indicator of disease severity. The diagnostic criteria for infectious mononucleosis involve 3 key components: clinical manifestations, laboratory evidence, and nonspecific laboratory indicators. Typical clinical manifestations include fever, pharyngitis, cervical lymphadenopathy, hepatomegaly, splenomegaly, and periorbital edema. Specific laboratory evidence include positivity for a VCA-IgM and VCA-IgG antibodies with negativity for EBNA-IgG, and positivity for VCA-IgG antibodies with low affinity antibodies. Nonspecific laboratory indicators include peripheral blood atypical lymphocyte proportion 10% or higher, and for children aged 6 and above, peripheral blood lymphocyte proportion greater than 50% or increased absolute lymphocyte count. Clinical diagnosis requires meeting any 3 clinical manifestations and any 1 nonspecific laboratory indicator, while confirmed cases necessitate meeting any 3 clinical manifestations and any 1 laboratory evidence. Thank you for watching this video. If you liked this video, to give it a thumbs up and share it. Do not forget to subscribe to the channel, if you still have not. You can click on the bell to receive notifications whenever a new video is uploaded.